All right, we are going to get started. And I know there are more folks registered, so we'll just let them mosey on in as they do. But I want to make sure we have enough time for everything. So thank you so much for joining us today. Um, Prevention intersections, thinking about the HIV/AIDS epidemic. Um, this epidemic is still very real today. But in addition, there are many lessons learned from the past 40 plus years that are related to our work because of intersectionality, but also transferable in terms of prevention strategies across the board. Next week is National HIV Testing Day, June 27th. So it felt like a good time to talk about the history, connections to IPV, marginalized populations, and our continued journey for health equity and justice. All right. So if folks don't know how to use Zoom, you're all muted right now, but you can unmute, you can raise your hand, you can put things in the chat and try to keep an eye on all of it. So that way we can answer questions, or if folks have, anything that they want to share that resonates, feel free. You can turn on closed captionings. You can also do other fun little emojis as well. So if you have any issues with any of that, just let us know. But also, interact as much as you feel able to. So I'm going to start off with a land acknowledgement. I'm going to put in the chat a link for folks to find out what their native land is that they're on. So that way folks can honor whose ever land they're on and become more aware of the history there. So we acknowledge that we are on the lands, um, excuse me, on the traditional territory and homelands of California Native peoples. These nations include over 120 federally recognized tribes and many other non-recognized tribes that are all very culturally diverse. We thank these nations for their generosity, and we keep them in our hearts and thoughts as we are in the space today, this week, and every day. I'm just going to get that in the chat for folks so you can learn whose land you're on. Okay. Also, it would be great to know where folks are coming from. So if in the chat, if you could put your name, your pronouns, your agency, your role, and your location. And now you can utilize that link I just gave you to add to your location. So I know folks will be doing that. I'm going to move on ahead, but I look forward to seeing who we have with us. Because I haven't introduced myself yet, so I wanted to get to this slide. I am Kimmy Remus, she, her pronouns. I'm a prevention specialist at the partnership, and I am calling in from Nipmuc, Agawam, Pawtucket, Massachusetts land. And I have with me two of my wonderful colleagues that are also on this page. We also have a fourth, our director, Jennifer. And actually, we need to update these slides because Miranda and Jennifer, you now, we house capacity building as well, but I'll let my amazing colleagues introduce themselves.
Hi, I'm Miranda Stiers, and I use they, them pronouns. I'm the Associate Director of Prevention and Capacity Building here at the partnership, and just very happy to be here. Did I say my lands? I'm joining.
No.
Okay, I'm sorry. I am joining from the lands of the Nisenan, Miwok, and Maidu people in what is now occupied Sacramento.
Good morning, everyone. I'm Melody Crispodin. I use she, her, AL pronouns. I am also a prevention specialist with the partnership, and I'm calling you from Tongva Land in Los Angeles, California.
Awesome. Thank you both. Okay. Apologies. It seems that there's a delay from when I click next slide to the slide actually advancing. So why are we here? And in the background, you can see this is the AIDS Memorial Quilt from the Names Project. It started in 1985, and actually with Wayne 54 tons. It's the largest piece of community folk art in the world as of 2020. I'm going to have lots of links that I will put in the chat throughout, so folks can get these resources or learn more about these things that I'm about to talk about. For me, this is also personal. My dad used to have two younger brothers who both passed away from complications of AIDS in the earlier parts of the epidemic, and it's greatly impacted my family through up until today. So there's still people who are grieving out there. There's still people whose families are impacted by HIV and AIDS. So it's still something that we need to talk about. Also, thank you for folks that I see that are introducing themselves in the chat. Okay, there it goes. See, again, takes a second. So this is not a full timeline, of course. This is just some highlights that we're going to talk about, but just to give you an idea of where we started from and where we are today. So we're starting this timeline in 1981, which is the first official reporting of an AIDS case. Now, there are reports in medical journals from the 50s and such about symptoms that we later then learn are AIDS, but they didn't have a name or something really to call that. So we officially start documenting in 1981, and that term AIDS for autoimmune deficiency syndrome, it comes up in 1982. Sorry, not autoimmune, acquired immune deficiency syndrome. So when you have alphabet soup constantly in our field, there are so many acronyms as there is on this page, so apologies. Then we have, so the next time, we have, as you can see, a lot of action kind of happening at the front. In 1983, we have our first hotline. It's the first time that there is funding from Congress dedicated to this research. And it's also, CDC thinks that injection use is the leading cause. So we're starting to see momentum happening. And then in 84, AIDS Action comes together. And so that's, there have been community-based AIDS service organizations starting all the way back into 1981. Well, actually, I think 1982, because Gay Men's Health Crisis was the first one that we know of in New York City. But we see all these organizations come together to form a national organization now, because this is becoming a national issue, a national widespread problem. I'm going to jump ahead a few years. 1987 is ACT, the first antiretroviral drug that comes out. I'm going to put what the name of it is in the chat. I do not want to try and pronounce it, especially since today I seem to be, probably my excitement of the topic is just jumping over the words. And so that's the very first time we actually have medicine around this. Then I'm going to jump ahead almost a decade to 95, where in 1995 we have our first National Testing Day. It's still June 27th as it was on that first day. And at this point, there have been about 500,000 cases of AIDS reported in the US. That's probably an undercount, as are most things when we try and measure, but to give an idea. We also then at this point in 2006, so you could see another large gap. There are still things happening, but we have a significant gap occurring. And that's the first time TASP, which is treatment as prevention, is a concept. It refers to taking HIV medication to prevent the sexual transmission of HIV, and you know, thinking that people who take medication can keep an undetectable viral load, a very low level of HIV in their blood, and can then live long and healthy lives and not transmit to partners. So that's the first time where that becomes really a concept. Then in 2012, we have our first at-home test, so folks can know their status right away. And it's the first time we have a pre-exposure prophylaxis, or PrEP. And for folks that don't know, there's also a thing called PEP, which is for post-exposure. So that's when that comes about. And then in 2016, we have undetectable equals untransmissible. So when I was saying before, that idea of treatment as prevention, that's the first time that we have it confirmed that if you have an undetectable viral load, that you do not transmit. So that was kind of a quick little, here's 40 years, and you can see we have a lot happening up front, and then there are larger gaps because it's becoming, I don't want to say less of a problem because it's still very active, but for people who were around then, and reports of then was just that people were dying constantly all over the place and something needed to be done. And now it's become a more manageable, treatable condition, as well as something that we know a lot about prevention. Hence why I'm talking about prevention strategies. So. There it goes. Okay. I don't know why it keeps doing that. I apologize. So this is the public health model. For those of you that don't know the public health model, I'm about to become a little bit nerdy on some theory. So this is from the CDC, and it's define the problem, identify risks and protective factors, develop test, prevention strategies, and assure widespread adoption. And so that's been applied to a lot of different public health problems. And I'm going to put the public health model in the chat as well as the timeline for the larger timeline from AIDS United that I borrowed from. And so if we go back to our previous slide, you can see that happening here. First, you have to even know there's a problem and define it. So that's what's happening in these early years here, right? Then we have identifying risk and protective factors. So that's when the CDC goes, okay, we know that people who use intravenous drugs seem to come up with this disease. Later on, we find out about that it is a sexually transmitted disease, can be transferred also by blood. So those are things that we have learned, but also figuring out risk and protective factors in terms of like having community-based organizations is a major protective factor of having the increased knowledge in society about having support, all those things. So we see that stuff begin to pop up. Then we have some strategies for prevention that we're trying. We're trying to, with the AZT, we're trying to prevent HIV from turning into AIDS. For those of you that don't know, HIV goes through a couple of different stages, and AIDS is the last stage of HIV, which is much more serious and leads to fatalities. And we also see, at-home testing. So there in the task, all those things I just mentioned, that's us trying out strategies to see what works. These aren't the only strategies. There's also clean needle exchanges. That's when folks start really learning about condom usage. So there's a lot going on here that we realize we can do with prevention, right? And then there's widespread adoption. So the knowledge of UU, more healthcare providers knowing about PrEP and PEP, regular testing being a part of just your health services. In some places, they don't have HIV health education, but in California, with the California Healthy Youth Act, which I will talk about, we do have required HIV education. I'm jumping ahead of my slides. And so it's something that folks know a lot more about. So that's kind of what we mean by that. Now, I also want to talk a little bit of theory about primary, secondary, and tertiary prevention. So primary prevention is stopping violence before it starts. It can also apply to this. So stopping an HIV infection from occurring in general. Again, that's with PrEP usage, that's with education, that's with our programs, that's with internal and external condom usage, clean needle exchange. Those are screening blood at blood drives. Those are primary prevention efforts. We also have secondary prevention, which that would be kind of so HIV has occurred, but we wanted to keep from either transmitting to someone else. So that's TASP, as we talked about. And it also is from keeping HIV from turning into AIDS. And so that's keeping the viral load low, making that UU. And then we have long-term tertiary responses, which those are increased funding in research, those community-based organizations that we know about being established, having networks, support for people who are dealing with HIV/AIDS, support for their families. And so this is what we use for violence prevention, but it also is applicable to the HIV/AIDS epidemic. Any questions so far? Okay, cool. Just let me know. I'm also going to put a link in the chat from where this graphic comes from, which is some violence prevention fundamentals from the CDC. All right. So people sometimes are shocked that this is still around. Some people feel like because it's not in the news as much anymore, or they know less people who have it, that it's kind of gone away. And it hasn't. You can see here, you know, this was from a couple of years ago, but, you know, still 32,000 approximately infections. We are seeing some intersections here. So the differences between the LGBTQ population and the heterosexual population. So the queer population is more susceptible. And so we need to be more considerate when we think about intersections and prevention. And also people who use intravenous drugs. Now, that is still a lot lower, thankfully. And the fun fact, the outbreak in Indiana in 2015, I believe it was thanks to former Vice President Mike Pence for destroying the funding for HIV prevention in the state of Indiana, and there was an outbreak. It's not really a fun fact, but it's just interesting to know that these are all important factors when you think about intersectionality, prevention, etc. And so there is a goal, though, to decrease HIV infections. So by next year, we're hoping under 10,000 infections, and by 2030, 3,000. I also want to point out that this is probably an undercount, but approximately 700,000 people have died of AIDS or complications of AIDS, excuse me, since the 80s that we know of. Again, that is most likely an undercount, and that's just in the US, that's not globally. Also, I am talking specifically about the US, I should say, because globally there are other parts of the world that are still seeing HIV/AIDS at horrific rates. So approximately 1.2 million people in the US have HIV currently, and about 13% don't know that they have it. Again, these are estimations, but of what we can extrapolate. So it's important to kind of know these things because, again, it illustrates that we still have work to do. So now we're going to start to get a little bit into how it relates to our work. So I did mention CHIA, which is the California Healthy Youth Act. And a lot of us work with Chaya because it's part of our work that we do within schools and with youth. Chaya is comprehensive, medically accurate, factual sexual health education that is supposed to go to all school systems, right? And so in the state of California, hence California Healthy Youth Act, not other countries, other states, some have different laws that ensure this. Some do not have any laws. Some have opt-in, opt-out laws. Anyway, I am getting ahead of myself, but a lot of us who teach about healthy relationships, because that is a major part of our work as preventionists, and that is a major part of Chaya, will also talk about HIV prevention, which is also required. So it's also interesting to note that advocates for youth said that they were able to estimate, based on responses, et cetera, that only 6% of high school students were ever tested for HIV. And I know I'm trying to think about I don't think that I was tested really until college, given it was a much newer thing. It wasn't available when I was younger. It was a much newer concept too, the home tests were a much newer concept, and they became more available at our health services, and we would have them at events on our college campus, but not until like probably my last year or so. So we have a lot of high school students who do not know their status and do not know if they could potentially pass this on to someone else, or if it's something that they need to be mindful of for their own health. Okay. So now, you're still probably going, okay, we're learning a lot about HIV AIDS. Thank you for teaching us, Kimmy. Or if you already know, okay, this is great review. But let's talk about it with intimate partner violence. So here are some different areas of intimate partner violence: emotional abuse, technological abuse, economic abuse. And when we think about intersectionality, which was a term coined by Kimberly Crenshaw in the 80s, it's about acknowledging other parts of a person that might impact how they are treated in the world. And also, when we think about those risk and protective factors, how it might add to that layer, right? So we're talking about health status here. And we're also talking about something that is highly stigmatized in our society. So can anyone think about how having HIV/AIDS might impact one of these areas of intimate partner violence? What do we think is a intersectionality aspect here?
I see it a lot of the time in the queer community where someone will get HIV or AIDS and then they're shamed out of trying to seek a new partner. So no one will want you because you have HIV, which is both an emotional abuse tactic and an isolation tactic.
Absolutely. Thank you so much, Maya. I could not have put that example better myself. That is absolutely something that we see happen. And as you could see with that example, sometimes it crosses over multiple sections of abuse at once. Does anyone else see anything with a population they work with, or just kind of thinking about what could be some intersectionality here? Thank you. I also seen the chat from Maya. It can also cross into technology. I'm going to expose you online. Absolutely. So I'm going to, the amount of times I say I'm going to put in the chat is probably ridiculous. But I am going to put in the chat in a second. We're a big fan of power and control wheels in domestic violence, right? So there is a power and control wheel from NNEDV in regards to HIV. So we got that great example from Maya that they shared with us. And We also can have a couple of other examples from it. So sometimes withholding medications, like we talked about, PrEP and PEP, that can be a method of abuse that folks use. Also kind of with that, maybe keeping them from seeking mental health services as well if they require it. Um, uh, Threats about outing their status with employers, friends, family. It can be a control issue saying, okay, you have to stay with me because otherwise, no one will have you because you have HIV. Oh, yes. My also puts financial abuse partner may not have the funds for their own medication. Absolutely. So they might be reliant in that regard. Um, there might be some coercion in regards to sexual reproductive health, about, um, you know, forcing sexual encounters, or withholding. Yes, I also put in the chat, no condom, no disclosure of status. Also kind of saying to someone you're sick, so you can't go out, or you're sick, you can't do this, so further isolation there. I could go on and on. And I see my husband putting just amazing things in the chat that, yes, well, they're not amazing, they're sad things in the chat, but they are great points to bring up. So there are ways that this kind of impacts heavily. And as Maya pointed out, and we also saw earlier, that this does impact the queer community. Historically as well, it was kind of known originally as a gay men's disease, gay cancer. That was coming up. We now know that it impacts all populations, but it does impact these groups more because they are also more likely to have poor health outcomes in general. They're more likely to have less access to care, more likely to um, have more stigma related to their care. So there are several factors there that we have to be mindful of when we're providing prevention services. So there are, I also put new infections in women who are partnered with men who have sex with men, or cheating as a form of power and control. Yes, that's also something that comes up as well. Also, we tend to notice now, oh, no worries. Thank you for being here, Barbara, as long as we could have you. There also, I'm gonna just go back for 1 second. There also is quite an issue right now of particularly Black women having HIV infections. And we can think about medical racism and that. Again, the parts of intersectionality that people have, that's not the reason that someone, it's not race, it's medical racism that someone might have. Not as great access to care or poorer health outcomes or being more likely to have HIV. But we've been noticing that as a spike in this century as well, because of some of those factors. And because people still will assume also that it is for queer folk. As you saw on that slide a couple back, heterosexual women still were a higher percentage than folks who used intravenous drugs. For getting new infections. And originally, that intravenous drug use was the cause that CDC was naming as the leading cause. So, this education and prevention is really important. And when we think about this in the context of gender based violence and racism and homophobia and transphobia, it's directly related to our work. Okay. So, things that we should know about as preventionists. So there are some rights and things that are available and extra services that people might not know. And it's important for us to be able to say to folks and help guide them of where they can receive help in services. So the Affordable Care Act was an important piece of legislature for a lot of reasons. I'm noticing now that I'm like dating myself that I'm starting to get people in groups who do not like remember a time where they couldn't be on their parents' health insurance until age 26 or that sort of thing. But this was really groundbreaking because you couldn't really get health insurance a lot with pre-existing conditions. And oh, um, I also just want to point out, since Gabby has to leave, that at East Los Angeles Women's Center, great organization, they're hosting a Seeking Safety course for HIV positive cisgender women. Wonderful. When they learn different skills to regulate emotions and break down stigma. If you have any questions or are interested, their emails in the chat. That sounds fascinating and completely tied to what we're talking about today. I will definitely be emailing Gabby as well. So back to what I was saying about the Affordable Care Act, or ACA, or sometimes it is called Obamacare because it was signed in the Obama administration, is that it allowed folks with HIV to not be denied health insurance, but it also allowed better care access. And another aspect of that was broader Medicaid eligibility. It also made those prescription drugs less expensive. So Maya was saying, you know, that unfortunately we still live in a society where these drugs are not free, but if you know, it did lower that burden, but that also could mean that, you know, still it, you know, if you can't afford something, you can't afford something. So that still is a power and control mechanism. It allowed for coverage of preventative services. So every time someone gets HIV tested at a doctor's office or something like that, that is covered. It covers PrEP as well for folks who are at risk. Coordinated care for those with chronic health conditions that might be a result of having HIV or AIDS. So there were several things that happened there that have allowed for greater expansion of services, and why we are at lower rates than we initially were, especially for folks who are, you know, have higher risk factors of becoming, you know, of having violence in their life. It might be important to have them know that they have this sort of medical care and options to them as well. Another portion of this is teen rates. So thinking back to that slide, only 6% of high school students, right? In 2021. I know we're in 2024, but I'm really not optimistic that number has gone up higher, right? So teen rates in California, if you are 12 and over, you can receive confidential STI testing, so sexually transmitted infection testing, mental health services, and drug counseling services. I'm going to put in the chat, it's a PDF of teen rights. And so that's something that a lot of youth don't know, because if we think of the barriers, again, intersectionality around youth and teens, you know, they worry, okay, will my parents know about this? Will I, you know, will it show up on our insurance? Will I have to have the provider let them know? And also we have to think about, for you know, our secondary prevention for folks who are already experiencing violence, particularly domestic violence, sexual violence, who are at risk for those reasons, knowing that you can still be a youth and receive these services, you know, in dire circumstances. If you are someone who is 12 and has been suffering, then you're able to receive services for that help. So, you know, it's not great to think about what people do to youth sometimes, but it is a part of our world as well. And also, again, thinking with intersectionality, that things could particularly happen to youth of underserved and marginalized populations. Another, though, wonderful thing about living in modern medical times is that people can have a healthy pregnancy. And it just was released as a new kind of statement from the American Academy of Pediatrics for the first time in 40 years. parents who are HIV positive can breastfeed now if their viral load is undetectable, which is huge. So if we think about what that means for health outcomes, also that can really, pregnancy and the first year of postpartum is a really dangerous time for someone in an intimate partner violent situation or at risk of becoming in one of those situations. So to be able to have agency over choices of how they feed their child, financially, that can be helpful for them as well. There are it is a tactic that then someone who causes abuse may not shame them for not being able to feed their kid. So there are a lot of ways that this spins off as well. So that is also a pretty exciting advancement that literally happened like this year in May. Okay. Any questions? Okay. A little more theory. Sorry. So the socio-ecological model um, is a model that you see on here. It's also from the CDC. And it shows different spheres of how we approach violence prevention. There are things that we can do individually, but ultimately these other aspects interpersonally and also in community society have to create the environments that are going to make it so people can thrive and violence doesn't occur. And this also happens with HIV and AIDS as well, or for people who are experiencing both of those things. Can anyone think of any aspects either of their work or about HIV prevention or violence prevention or all the above and where they would fit on this socio-ecological model? Are they individual changes of behavior? Are they things between people? Is it stuff in the community or larger societal things like laws that we have, policies? Okay. I'm seeing in the chat. Oh, more information, thank you, from Thelma about East Los Angeles Women's Center seeking safety course for HIV positive women. Awesome. Okay, so maybe in a community, making sure that confidential STI testing and partner notification programs are free and accessible, that they're non-stigmatizing and youth-friendly could be one. We could see maybe structurally, we can see society eventually, if we think of that public health model, assuring the widespread adoption, the changing of stigma occur. There are still laws that inhibit or that prohibit progress from being made. So there's only, like, for example, a partial repeal on the use of federal money to pay for sterile syringes. So that could be something on a larger societal level. Maya says at the relationship and individual level, continue to educate teens about STI testing, using protection, but also including disclosing status, skills building, and consent education models. Absolutely. Yeah, when we teach youth how to have healthy and honest conversations, that's a really important part. Discussing boundaries, discussing, hey, this is my status, but here is how we could still safely engage if we both consent to. And does anyone else do any of this work currently? Or maybe let me get a pulse check in the chat. Are folks, so I've seen a couple people in the chat mention that they are already doing work around HIV AIDS, but are any folks doing, work as well, or is this something that you're hoping to learn more about and incorporate in your violence prevention work? We're a little quiet this morning. That's okay. I know yesterday was a holiday too, so sometimes coming back is um a little bit hard. All right, so I'm gonna move on about so this is the AIDS Action logo. Um and it's not necessarily to say about this organization specifically, but it is my little kind of thing to say, what are some actionable things that we can do, right? Um, and so one of the things that we can do, advocacy, always a big fan of advocacy. Um, there is something also happening right now. So some of you may have heard in the news about the Comstock Act, usually hearing it in regards to either abortion medications or around supplies for a procedural abortion. But the Comstock Act, in a very aggressive reading, could go as far as to ban HIV prevention medications, clean needle exchanges, gender affirming care. And so that is also something to actively advocate for Congress to repeal, because it's been on the books since the 1800s and it's very dangerous. Also, sometimes it might be said in the news as 18 US Code 1461, that so they don't say Comstock because people maybe have heard that phrase. But that is a very active thing happening right now that we could use some advocacy probably to appeal. In states that do not have Medicaid expansion, there can be advocacy done there. So that way that care does become more active and accessible for folks. So advocacy is always a thing that we can do. Of course, advocating for prevention dollars. We have an annual budget ask every year. So these are larger societal things, but also think about in communities too about what folks can do to advocate. Maybe advocate that services are on school campuses. If they are doing testing for, I've noticed a lot that sometimes there'll be STI testing for chlamydia, gonorrhea, and trick, just to be like a catch-all. And HIV is very common. That should be included in the standard STI screens, right? So that could be something to advocate with healthcare providers around. Figuring out how to maybe do events around National Testing Day in your communities. Bringing together, culturally specific cohorts. So if we're thinking about, there's that training coming up for cisgender women, thinking about the queer population. How are those all things that we can maybe bring to action? Does anyone else have any ideas or thoughts around what we could be doing, or what you can do in your own community? Okay, nothing heard. That's right, maybe folks are just absorbing. I'm going to give another couple of resources to have in your back pocket, all right? So here are some resources. So one is the HIV Positive app. This is a tool that folks can have on their phone to teach patients about HIV prevention, offer guidance on how to get screened, to find out information about new medicines. It's for Android and iPhone, but it shows up in your screen as like health flow. So it has that privacy idea of, oh, it's just a health app. So people don't necessarily see, oh, you have an HIV app on your phone. So that's one of the resources that I wanted to share. We also have together Take Me at Home, which is for free at home tests, because sometimes the cost is a barrier to those types of things, or they do not know where you can get them. Also, NNEDV has Positively Safe, which is a program around addressing the intersection of domestic violence and HIV. So it has a couple of their partner organizations listed. It has some basic facts. It has toolkits. It has a really nice podcast expanding the continuum around these intersections. So they're a really great resource. And then also, because this is, we are the California Partnership to End Domestic Violence, I'm going to put in the California Department of Health Office of AIDS, which has a variety of resources for finding local services, for funding, for quick guides, on how to do PrEP. It's shocking the amount of healthcare providers that actually do not know about PrEP. So those are all resources that are available, and there are plenty more as well. That's only just a very small list. It sounds like certain organizations like the East LA Women Center, it does a lot of great work around this too. I will put in the chat in a minute our upcoming events, but we also have our peer learning circles, and one of them is prevention with LGBTQIA plus communities. So I know we talked about how they are not the only population, of course, but they are a population that does have higher rates, and so we want to make sure that we are able to, oh, can I go back a slide? Absolutely. This will also all be available on our resource library as well tomorrow. Hopefully tomorrow, if not by Monday. Sometimes it takes a little time to upload stuff. Are folks getting what they need out of me going back a slide? Okay. I just want to make sure before I move on, I don't want to rush anything. So I'm also, because this was not originally going to be part of my resources, but I am going to put our resource library in the chat as well. Because, okay, well, the link just says Partnership to End Domestic Violence. But the tabs on the far right is one that says resources. That's how you access our resource library. So I mentioned our peer learning circles. We also have a monthly newsletter. You can always contact me, but coming up, we have a few other things happening going on. We have our conference is going to be next week, and you actually can get CEUs. It's the first time we've been able to offer that. So we're really excited about that. So sign up. You have up until the day before, actually, even for registration. I checked. And then next week on Friday, we have our Prevention Peer Network call, which is Pride is Still a Protest. Kind of in a similar vein of HIV/AIDS is still something we need to talk about. Pride is a wonderful celebration, and it is something that also is still a protest because of what's going on in society, and that we still need to continually fight for our rights. Does anyone have any questions about any of that or anything else that I said so far? Anything that folks want to add? I know today is a little bit more of a lecture webinar. The peer learning circles and the call that are coming up are a lot more like facilitated discussion. So it depends on what you might be looking for, or what might be a more comfortable venue for you. Or if you're just happy to listen about a new topic, then our webinars are great. Okay. So that's actually my presentation for today. We're ending a little bit early. Do folks have anything else that they want to share or talk about, ask about? If not, I hope to see you at some of the other upcoming things. Thank you so much for those who contributed. Oh, I'm glad. Thank you, Chrissy. I'm glad that you liked it. Thanks, Griselda. That's very helpful when we're having a slightly quieter morning to see in the chat if this is something that folks have found helpful. So that way, you know, we know for future topics what is resonating and what's not. All right, well, I am going to end the slideshow and stop recording in a second. If it will let me bring that up. All right.